Welcome to Pathology Central Key Concepts. The topic of this video is prostate pathology. In this video, I'll be focusing on benign prostatic hyperplasia and adenocarcinoma of the prostate. Let's begin with a quick review of prostate anatomy. Here you can see the organ nestled between the bladder and the rectum. We divide the prostate into a variety of zones. We have the peripheral zone here in light yellow, which is the most common location for adenocarcinomas to arise. A subset of these can be recognized on digital rectal exam. There's also the central zone and the transition zone. Please appreciate here the urethra traveling through the prostate. Most benign prostatic hyperplasia is going to rise here in the transition zone, and you can see why urinary obstruction is a major component of that disease. So with that in mind, let's begin with benign prostatic hyperplasia. In BPH, we see proliferation of both glands and stroma. There's increasing frequency with increasing age, and in fact, about 90% of men in the 8th decade of life have some degree of benign prostatic hyperplasia. Therefore, it is an important cause of urinary obstruction. Please do remember, however, that BPH is not a premalignant lesion, and patients with this disease do not have an increased risk of malignancy. Now let's take a moment to review the normal physiology of the prostate, because I think this will help you understand both BPH and adenocarcinoma of the prostate. This comes from Robbins and Kumar Pathologic Basis of Disease. So as you'll recall, in the prostate we have both stromal cells and epithelial cells, both of which can take up testosterone. However, only stromal cells have the enzyme 5-alpha reductase type 2, which can convert testosterone to the much more biologically active dihydrotestosterone, or DHT. DHT can be shared from the stromal cells to the epithelial cells and can bind to androgen receptors in both cell types to activate transcription of androgen-dependent genes such as transforming growth factor beta, insulin-like growth factor, epidermal growth factor, and keratinocyte growth factor. And these growth factors can act either in an autocrine fashion, so being released by the stromal cell, binding to a receptor on that stromal cell, stimulating growth, or they can act in a paracrine fashion, so this growth factor goes from the stromal cell to stimulate growth of the epithelial cell. Now, typically, we have a balance between our epithelial cell proliferation and our cell death, and the prostate remains its usual size. However, if we have some imbalance leading to increased cell proliferation and decreased cell death, we can get hyperplasia. So this balance is maintained between transforming growth factor beta, which is going to drive towards cell death, and epithelial cell proliferation, which is driven by these growth factors. So what is it that's going to cause this balance to shift? It's thought that one of the contributors is going to be estrogens. Remember that all humans will have estrogen and testosterone. And as individuals age, we can see a change in these hormone levels. So as men age, they'll have decrease in testosterone and increase in estrogen. And perhaps this is what tips the balance towards proliferation, leading to prostatic hyperplasia. Now, there are a couple of different estrogen receptors in the prostate, both alpha and beta. They have opposing activities. One's proliferative, the other's anti-proliferative, and they manifest this through a variety of different pathways using apoptosis, aromatase expression, and paracrine regulation via prostaglandins. So we can see here, for example, when we have excess estrogen, it is going to decrease cell death, and it's going to increase cell proliferation, driving us towards our prostatic hyperplasia. So what do we see in BPH? The prostate will be enlarged and nodular. It can be 3 to 5-fold larger than the typical prostate and may weigh 60 to 100 grams or more. In the early stages, the transition zone is where most of the growth will be seen, and it will compress the urethra. However, I'll show you an example on the next slide that shows a very advanced image that shows how nodular the entire prostate can become. Histologically, we will see proliferations of both glands and stroma. These glands will be lined by a hyperplastic epithelium, and we will see these flattened basal cells. They can be difficult to recognize, so we may use immunohistochemistry to highlight them. In addition, we can see proteinaceous concretions, which are called corpora amylaceae. So here is a gross specimen of prostate. You can see how nodular this is. The nodules may be composed of glands or of the fibromuscular stroma. You can appreciate here how the urethra has been compressed into this slit-like orifice. You can see that on this whole mount section as well. Here you can see that in this particular specimen, the nodules are composed of proliferating glands without so much stromal proliferation. This low power view shows not only this hyperplasia of the prostatic epithelium, but also here's a corpora amylacia. Let's look on higher power so you can appreciate what is going on with this hyperplastic epithelium. Here you can see that the epithelium is thrown up into folds and arches, and we have here where these arrows are demonstrating some basal cells. Again, these are very subtle and can be hard to recognize. Most patients with BPH will present with some sequela secondary to urinary obstruction. With this compression of the urethra, we can get increased pressure leading to bladder hypertrophy and distension. When the patient attempts to empty the bladder, there will be residual urine, which is a setup for infection from bacteria. It also leads to the feeling that the bladder is not completely empty, leading to urinary frequency. We can also see hesitancy, dysuria, and difficulty starting and stopping flow. Nocturia, which is urinating in the night, is one of the more common presentations of BPH. We have two types of treatment, medical and surgical. So medical treatment will use, for example, alpha-adrenergic blockers to relax the prostatic smooth muscle, allowing urine to flow. And 5-alpha reductase inhibitors will inhibit the formation of DHT from testosterone. In addition, we can do surgical approaches such as a transurethral resection of prostate or TURP, laser therapy, hyperthermia, etc. So this brings us now to adenocarcinoma of the prostate. This is the most common malignancy in men and accounts for about 20% of male cancer cases in the United States. It is the second leading cause of cancer-related death in men, second only to carcinoma of the lung. However, hidden in this is the fact that the natural history of prostatic adenocarcinoma is variable. So for many patients, this can be a very slow and indolent lesion. This is why it is often said that more men die with prostate cancer than of prostate cancer. However, there are subsets that are aggressive and rapidly fatal. The pathogenesis is related to these 4 factors: androgens, heredity, environmental factors, and acquired somatic mutations and epigenetic factors. So let's go through these. So androgens are, of course, central to prostatic adenocarcinoma. We know that they're necessary for carcinogenesis. If an individual has had an orchiectomy, a bilateral orchiectomy prior to puberty, that male will no longer be at risk for prostatic adenocarcinoma. We also know that androgens are necessary for the maintenance of established cancers, in part because if we do androgen blockade, this can lead to tumor regression. However, this is not stable. Additional mutations can develop. For example, we can get amplification of the androgen receptor gene, which will increase sensitivity of the tumor cells to lower androgen levels. In addition, we can get mutations and epigenetic changes that lead to alternative signaling pathways that bypass the need for androgens. There are a variety of acquired genetic and epigenetic alterations, such as chromosomal rearrangement, which is seen in about 50% of cases of prostate cancer. This brings one of the ETS family transcription factors in juxtaposition to the androgen-related TMPRSS2 promoter. We can also see amplifications of MYC and deletions of P10, which are thought to increase cell growth. Remember, MYC is a pro-growth protein and may also increase resistance to anti-androgens. In early stage disease, we tend to see epigenetic silencing of a protein called glutathione S transferase pi1. This is a protein that plays a role in the detoxification of xenobiotics and can contribute to the environmental context that gives rise to prostate cancer. In late-stage disease, as we've got additional mutations, we tend to see loss of P53 and RB function, again with amplifications of the androgen receptor. And then finally, looking at heredity and environmental factors, we know there's an increased risk in first-degree relatives and germline variants in the regulation of MYC, as well as different types of DNA repair have been identified. A Western diet is associated with an increased risk, and it's thought that exposure to toxins and estrogens also plays a role. So here's a really nice figure from Robbins and pathologic basis of disease, showing our progression. So we begin here with healthy prostatic epithelium that is exposed to dietary exposure or toxins, chronic inflammation, androgens, germline MYC variants, something that begins this process that will lead us to prostatic intraepithelial neoplasia. So this is a pre-malignant lesion, a precursor lesion that with additional changes such as the TMPRSS-ETS fusion or silencing of GSTP1, we can get the development of a localized prostatic adenocarcinoma. With additional losses such as P10 or activation of telomerase, we have now enabled more widespread metastasis to lymph nodes as well as to the skeletal system, a common site of metastases in prostate cancer. And if this patient is being treated with medical management, we can get additional mutations that will eventually develop in the residual cancer, loss of P53 and RB, AR amplifications, and at this point we will have an aggressive treatment-resistant cancer that no longer responds to androgen blockade. Morphologically, about 90% of these arise in the peripheral zone, typically posterior, and on cut surface will be gritty and firm, but it may be difficult to discern prostate cancer from uninvolved prostate. About 80% of cases of carcinoma have associated prostatic intraepithelial neoplasia, in which we have dysplasia of the nuclei and some additional features, but we maintain our basal cells. So the classic finding, the critical criterion here will be loss of our basal cell layer. Now, the cancer may be very well differentiated with simply crowded but well-defined glands, or it may be sheets or single cells of malignant cells. The nuclei are typically enlarged with prominent nucleoli. Now, to give you a look at this gross, I'm going to compare it with what we saw in BPH. So there are a couple of nice features to recognize. One is the prostate in prostatic adenocarcinoma is much smaller, and the urethra is patent, not this slit-like form. We don't have that nodular architecture. In fact, the nodule that we see here is very poorly defined. It's an area of solid tissue which lacks the glands that we can see here. We can only be sure of the diagnosis by looking at it under the microscope. So here's what we would see under the microscope. These areas here, these darker glands, are the invasive carcinoma. They're surrounded by normal, healthy glands. The way that we recognize it is that these are crowded together. They have some variation in their size and shape, and when we look on higher power, we're going to see that they lack their basal cells. So let's look here. Again, healthy, normal prostatic epithelium here with its basal cell layer. Here we have our prostate cancer. Look how large this nucleus is. Look at that very prominent nucleolus. Here's another one. This is our invasive carcinoma. Now, things get very complicated once we start talking about grading. You're familiar with the fact that most of the time we have 3 grades: well differentiated, moderately differentiated, and poorly differentiated. But what we have in the prostate is 5 grades, and they're based on the glandular pattern of growth. We very rarely use grades 1 or 2. They would be defined by well-formed glands that are similar to benign prostatic tissue. Grade 3 is typically where we start, where we see crowding of these moderately differentiated glands. And we can move up to grade 5, in which we have sheets, cords, or single cells. Now, the way we grade this is also different from how we grade other tumors. Typically, we'll say, well, it's a well-differentiated squamous cell carcinoma of the lung. What we do in Gleason grading is we assign 2 grades. We look at the most prevalent pattern and give that as our first number, and the second most prevalent pattern is our second number. That makes our Gleason score. So for example, if our most common pattern is going to be grade 3, and our second most common pattern, and it may be only a small part, we would call that a 3 plus 4 equals 7. If we have only one pattern present, then we will double it, so a 3 plus 3 equals 6. Now, the significance for you as future physicians is that most potentially treatable cancers will have scores of 6 or 7. By the time we see something that's an 8 or a 10, it is typically no longer localized to the prostate and is more advanced. Now, here are some images of these different grades. I don't think that anyone would expect you to be able to make the grade of these different types, but it's useful for you to look at them, I think, to understand the process. So this again gets to our features of malignancy. In grade 3, we look very similar to healthy normal prostate tissue with well-formed glands that are a little bit crowded, showing enlarged nuclei and an absence of our basal cell layer. By the time we get to grade 4, we have architectural features such as cribriforming, so a lumen within a lumen, so a gland within a gland. And then in grade 5, we have this simple sheets of cells. It gets even more confusing. We have recently started using grade groups, and this relates to the way of how we grade the prostate cancer. Remember, a Gleason score has 2 numbers. It can be either a 3 plus 4 or 4 plus 3. But the truth of the matter is that since this first number is going to refer to the most prevalent, we have seen epidemiologically that patients who are 3 plus 4 have a better prognosis than patients with 4 plus 3, which makes intuitive sense since there is here a predominance of well-formed glands, here a predominance of poorly formed glands. All of this information goes into the hopper as we define treatment, and I'll describe that in a moment. So in the United States, most prostate cancers are non-palpable and asymptomatic, and they are identified due to an increase in prostate-specific antigen, or PSA, that is detected in screening. So PSA is produced by prostatic epithelium, so it is organ-specific, but it is not cancer-specific. So this means it is not specific or sensitive for prostate cancer screening. What do we mean by this? That we can see elevations of PSA in patients with benign processes like benign prostatic hyperplasia or prostatitis. And on the other hand, we can have patients who do have cancer but have a low PSA. So this has become somewhat controversial, and it is part of the dialogue that is necessary when you are working with your patient. The reason is that, as I mentioned, many prostate cancers are indolent. So when you make this diagnosis, it's possible to overtreat the patient, leading to complications such as impotence or urinary incontinence. PSA is useful, however, when we monitor response to treatment and also keep an eye out for recurrence. So for example, if you have a patient who has an elevated PSA, he undergoes a radical prostatectomy, PSA levels drop to near 0. 6 months later, they begin to increase. Then you can suspect there's residual disease. So finally, regarding the tumors themselves, as I mentioned, about 70 to 90% are peripheral, and a subset of those can be identified on digital rectal exam. Another important feature about prostate cancer is that, as I mentioned before, it tends to metastasize to the skeleton, and these metastases are bone-forming or osteoblastic. This is different from what we see with most skeletal metastases, which are lytic, so leaving punched-out lesions, for example, breast cancer or lung cancer. So if you see an x-ray of an older male with osteoblastic lesions, prostate cancer is something that must be excluded. And here is just an example of a vertebral column which shows multiple metastatic foci of prostatic adenocarcinoma. So how do we come up with therapy for our patients? So there are a lot of considerations. So we want to look at our Gleason score, our grade group, the tumor volume, the tumor extent, so that's looking at staging, what's the PSA level, the patient age, comorbidities, etc. So this is a very involved discussion for you to have with your patient. There are a variety of therapeutic possibilities that can be used alone or in combination. Radical prostatectomy is typically the surgical approach. There can be a robot assist on this as well. Radiation therapy, either external beam or brachytherapy, in which radioactive beads are implanted into the prostate, can be used. And these can be combined with androgen deprivation therapy. So many decades ago, a male with prostate cancer would be given an option of a bilateral orchiectomy to remove testosterone. We don't do that nowadays. We would use a medical therapy, so a synthetic agonist of luteinizing hormone-releasing hormone, LHRH, which will cause a decrease in testosterone production by the testis. This can lead to an initial remission. However, as you saw from our discussion of the genetic situation for prostate cancer, we can get additional androgen-independent clones leading to disease progression. However, another thing to keep in mind is that the 15-year survival is greater than 90%. So this is in part a reflection of the fact that many of these are indolent tumors. I do want to highlight, however, that much of the discussion around prostate cancer discusses variations in mortality rates and disease aggressiveness based on socially defined race. There is definitely increased mortality in systemically marginalized populations, so please do keep that in mind when you are working with your patients. As always, here are some questions for you to test your knowledge that you've gained in the last 20 minutes or so. Thank you very much for your time and attention. Please do subscribe. I sure would appreciate it. Thank you very much.